Hi, this is Tom Shannon. In this presentation, we are going to be talking about how we make the diagnosis in prostate cancer. It's important to understand that prostate cancer is a journey, and I like to split this into two very distinct phases, which are the diagnosis and the treatment. I think this is really important because people often assume that as soon as you're diagnosed with prostate cancer, you will undergo a treatment. Prostate cancer isn't that sort of disease. However, if we don't diagnose your disease, we're not able to offer a treatment choice. And it's important, in my mind, that most men know what their risks are of prostate cancer, and if they are at risk, that they have the test to exclude the disease. The more cancer that we diagnose, the less likely we will be in having disease present late at an incurable stage. The second phase is treatment, and treatment does involve decision making and then the execution of the treatment. So looking at diagnosis, our aim must be to find the significant disease that will cause harm and by intervening prevent death or damage from this disease. We do need to be mindful that we can detect disease that won't cause harm. We can also miss disease that will cause harm, and this can lead to the diagnosis of disease too late to make a difference. The vast majority of these cases are when PSA testing has not been done. The way that we are able to maximize the benefits and minimize the risks of prostate cancer testing is by using all the available tools. Now, this goes well beyond just the PSA blood test. However, this is the most important initial test to be done. We also perform a digital rectal examination and often these days a multi-parametric MRI. An accurate biopsy needs to be performed, and the grade and stage of the cancer needs to be interpreted by an experienced pathologist. The PSA test is the mainstay of our efforts at early detection. PSA is a protein that is made in the prostate that liquefies semen at ejaculation. A high or rising PSA may indicate cancer, as cancer cells can leak PSA into the bloodstream at around 10 times the rate of a normal cell. PSA testing first emerged in the 1990s and has significantly changed prostate cancer from a disease of old men at late stage to a disease we are detecting at a time and a place where we can cure the cancer. The normal PSA ranges need to be interpreted based on a patient's age, and if you're under the age of 50, the PSA that would be considered abnormal is generally above 2. This rises to 3 at below 60 and around 4 at 70. It's important to note that the median PSA is the 50th percentile, or the middle of the group. Anyone with a PSA above the median is considered to be at higher long-term risk of prostate cancer. These levels are quite low on this chart, and it is most important that the median PSA is used in younger patients with the aim of identifying people who should be watched more closely than others. Other conditions affecting PSA fall into two groups. Those that generally raise PSA but are not cancer are things like a large prostate, and it stands to reason that a large prostate will make more PSA. Any type of trauma to the prostate, including ejaculation, a urinary tract infection, urinary retention, or having a catheter passed, will also push the prostate-specific antigen up. Prostate biopsy and prostatitis can push the PSA up significantly. Finasteride and dutasteride are drugs which lower the PSA by reducing the testosterone levels within the prostate gland. These drugs are commonly used to reduce hair loss or to shrink the prostate. Aspirin and ibuprofen are common anti-inflammatories that reduce PSA. and there are many prostate supplements on the market with natural or synthetic compounds that can lower the PSA levels. Obesity is becoming more common and is also a common cause of a suppressed PSA. We know that obese people have higher rates of prostate cancer, but also tend to present later as the PSA can be reduced. If a patient has had a rebore of the prostate or a TURP or any other ablative therapy such as tuna or HIFU, the PSA will naturally fall as they have less prostate tissue. This means that normal PSA reference ranges cannot apply. Other problems with PSA is that on its own, PSA does not diagnose cancer. It can be elevated when there is no cancer there, and it can be normal when cancer is present. Very bad cancers often do not show PSA, but thankfully these are rare. PSA can also detect disease that will do no harm. We know that all screening tests will pick up disease that may not harm, and that can obviously lead to psychological distress or harm from over-treatment. The main issue with PSA testing probably does not lie with the test itself, as it does what we want it to do in raising our suspicion that a cancer would be present. It is more likely that the biopsy is to blame, as a transrectal ultrasound-guided biopsy is a blind procedure which does not discriminate between high and low risk disease. We'll talk about this a little further down in the presentation. The concept of over-detection is one of detecting disease that will not harm. It is actually impossible to detect all the disease that will harm without detecting some disease that will not. In the instance of prostate cancer, detecting the disease on its own is one part of the equation, but the real harm comes when these patients are treated. There is a major push amongst urologists to minimize the harm of screening by not treating those patients who do not benefit. So to minimize over-detection, we use PSA dynamics, which look at the velocity or change in PSA, plus a free-to-total ratio or pro-PSA. We like to biopsy only those who will benefit from detection due to their age or comorbidities. If the patient has less than a 7-year life expectancy, we do not expect that they'll benefit from having a cancer diagnosed. Multiparametric MRI is set to change the diagnosis of prostate cancer and has a great advantage in only being able to see disease that is likely to cause harm. This will be expanded on in a further presentation. Rectal examination can be useful in the elderly, in that if a disease is not palpable, it's unlikely to be of clinical significance. Targeted biopsy is also changing the way that we deal and diagnose prostate cancer. If a biopsy is only done to an area where the prostate is suspicious for cancer, this reduces the rate of over-detection by up to 95%. The rectal examination is still an important part of the diagnosis of prostate cancer. It's a simple, quick and cheap test. The prostate is easy to feel inside the rectum, and a lump may suggest cancer. The importance of the DRE is that these cancers are often the types that do not produce PSA and may only be detected by the rectal examination. Most cancers these days, however, are not palpable on digital rectal examination, and a normal DRE does not exclude a cancer. For this reason, recent guidelines have suggested omitting the DRE. Multiparametric MRI, when used before diagnosis, reduces the need for biopsy by around 50%. It does this because it is able to exclude a cancer by showing normal, functional and anatomical changes within the prostate. On the other side, it also improves the detection rate of significant disease by 20%, as the cancers are often in areas where we would not routinely biopsy. This then leads to a reduction in the detection of low-risk disease by over 90%, which is a major step forward in the diagnosis of prostate cancer. MRI has the ability to determine the severity of a cancer before a biopsy, and it is also very useful to use in patients who previously had a negative biopsy and a rising PSA. This is a slide captured from an MRI showing 3 different images. The 2 images to the left are our diffusion weighted images. These images show us how water moves around in the tissue. When a cancer is present, there are more cells, leading to less water between the tissues. This results in restricted diffusion of that water, and as MRI is a test that looks at the water in the body, this can be generated into an image. The degree of restriction to the diffusion lets us know how severe a cancer is. On the image on the left, our B image shows a whiter, brighter area towards the right side of the gland, which is the left side of the image. This corresponds to an area of low signal on the apparent diffusion coefficient. This is seen as a dark area in the same region on the ADC map. The normal signal for this tissue should be the whiter, brighter signal below. The picture on the right is our anatomical image showing a T2 weighted image. Again, the peripheral gland tends to be whiter and brighter. There is a loss of signal intensity in the anterior horn of the peripheral zone to the right side, and this is a cancer. This patient had had a high-grade cancer diagnosed, and you can see that the tumour is near the front of the prostate gland. So multiparametric MRI can also confirm the tumour location. It can exclude second, more significant tumours, which allows for planning for surgery, especially in the area of nerve sparing. It can stage the lymph nodes and the bones as well. This is another slide showing a multiparametric MRI, again with restricted diffusion and low T2 signal anteriorly. The whole mount specimen from this patient shows the area in black to correspond to a cancer in the region of restricted diffusion well away from erection nerves. This patient had a very high-grade cancer yet was able to undergo nerve-sparing surgery. We'll talk more about MRI in a subsequent presentation. Thanks for listening.